Good morning, and I hope everybody enjoyed yesterday's great Congress. Today, we're going to start another day, and we're going to start with the Young Investigator Awards. This is actually a very important part in our Congress, and we always want our young investigators to be recognized and acknowledged for their great work. And it also shapes our future of the pediatric pulmonology across the world, actually, across Asia. And so this time, among the 130 more abstracts, we have chosen 11 uh, abstracts to get the presentation. So this will be divided into two parts. In the morning, the first part will be about original research, and in the afternoon, the other part will be about clinical case reports. So in each part, we will have, for everyone to present their work, we will have 7 minutes video pre-recorded part. And another is very important. After the presentation is done, there will be 2.5 minutes for the QA section, which is live. So please, all the participants in the Congress, you are welcome to provide your questions or problems inside our chat room, and we can give the moderator for the chance to ask them the questions. And also the international reviewers, please remember to give your scoring, because we're going to choose among the 11 participants their order and for the great presentation they have done in the end of this meeting in the award ceremony. So let's uh, let's enjoy the show. And today, this morning, we're going to start with the moderator, Professor Yu Zhilin, please.
Thank you. Good morning, everybody. Um, I'm Yi from National Cheng Kung University Hospital, and I will moderate the first two talks this morning. And the title of the first talk this morning is Air Pollution and Neurologic Factors Have Distinct Effects on Asthma Exacerbation for Young Children and Elders, presented by Dr. An Cai from Kaohsiung Changgen Memorial Hospital. So please play the video for this talk.
This is Dr. Tian Tai speaking from Kaohsiung Changgen Memorial Hospital in Taiwan. It's an honor to have this opportunity to present our research results about how air pollution and meteorological factors affect asthma exacerbation for young children and the elders. Asthma is one of the common airway diseases from young to old. Environmental factors contribute to the development and exacerbation of asthma. Allergen exposure resulting in asthma attacks is undoubtedly. Besides that, air pollution promoting the occurrence and progression of asthma through several mechanisms has been reported. Some meteorological factors, including temperatures, atmospheric pressure, and humidity, are also related to asthmatic acute attacks. In the real world, dynamic changes of air pollutants and meteorological factors always coexist simultaneously. If only single pollutant or meteorological factor is focused on, its health effect may be overlooked. Therefore, we designed a comprehensive study to determine the influence of air pollution and meteorological factors on asthma acute exacerbation. We focus on young children and the elders because these groups are especially susceptible to environmental changes. The records of emergency room visits due to asthma acute exacerbation were collected from the Taiwan National Health Insurance Research Database from 2005 and traced to 2013. Relevant air pollutants such as sulfur dioxide, nitrogen dioxide, ozone, carbon monoxide, particulate matter 2.5 micrometers, and particulate matter 10 micrometers. The meteorological factors like temperature, rainfall, and humidity were collected from the Environmental Protection Agency monitoring stations. A bi-directional case crossover analysis was used to investigate the effects of air pollution and meteorological factors on asthma acute exacerbation. Each emergency room visit for asthma acute exacerbation was defined as the case day. The same weekdays 1, 2, or 3 weeks before and after emergency room visits for asthma were defined as the control days. For the same person, we compared outdoor pollution or meteorological factor exposure on the case day with air pollution exposure on the control days. The primary outcome measured was emergency room visits for asthma acute exacerbation. Individuals who were included had a diagnosis of asthma as a principal or secondary condition according to ICD-9 code. The study population was further divided into subgroups according to gender or age. Air pollution generally had a 48-leg effect. Therefore, we used the 48-hour moving averages of air pollutant concentrations and meteorological factors for the regression model. For other meteorological factors like humidity and rainfall, the 24-hour average was used for analysis. According to our data analysis, we found that air pollution and meteorological factors mutually influence each other. For example, the degree of correlation of PM10 micrometers and PM2.5 micrometers is high. Outdoor air nitrogen dioxide and carbon monoxide were also highly correlated. Our results showed a decrease in outdoor air pollution with rainfall and more severe air pollution during the cold season. The gray column is monthly number of visits to the emergency room for asthma. The red curve is mean value of PM2.5 micrometers, and the blue curve is mean value of temperature across all locations. We found that there were more emergency room visits due to asthma in the winter and spring, and the value of PM2.5 micrometers was higher during these seasons. Therefore, the contribution of each air pollutant and meteorological factor for asthma emergency room visit is needed to be further clarified. This is the relationship of air pollution or meteorological factors with emergency room visits for asthma in a case crossover study without stratification by age. The analysis showed that the increase in value of PM2.5 micrometers and the decrease in temperature or sulfur dioxide were associated with more asthma emergency room visits. If the group of young children less than 5-year-old was focused on, the analysis showed that there was no correlation between the air pollutants or meteorological factors and asthma acute exacerbation. For the elders, it seemed the increase in value of PM2.5 micrometers is a risk factor for asthma emergency room visits for male elders aged more than 65 years old. Our conclusion is in Taiwan, dynamic changes of air pollutant and meteorological factors coexist simultaneously, and asthma acute exacerbation is closely related to low temperature and certain air pollution. The influence of air pollution and meteorological factors leading to asthma acute exacerbation is age and air pollutant dependent. The effect of certain air pollutants was not exactly the same among different age groups. Previous studies show a stronger association between outdoor air pollution and emergency room visits for asthma among children less than 5-year-old with or without statistically significant. But in our study, younger children less than 5-year-old were not more susceptible to the effect of outdoor air pollution and meteorological factor for asthma acute exacerbation than older children. The difficulties of asthma diagnosis in younger children, a higher prevalence of respiratory tract infection, and lifestyle difference among countries may cause these different results. For example, infants and toddlers stay at home more often and active outside in Taiwan. This is my presentation, and thanks for your attention.
Okay, thank you for your presentation. Okay, maybe I can ask the first question. For the patient of case visiting ER, do they have a repeat asthma attack that they would visit ER on the control days? So for the case visiting ER, do they have repeat attack of asthma exacerbation that they would visit ER on the control day. What I mean?
Yeah. This is a good question. Yes. For the person who go to the ER for the help of acute asthma exacerbation, and it is possible for the chance to visit for the second time on the control days. Yeah, but because
So how
our
do you define the case and control day in that kind of situation?
Well, we will know the situation from the database from the Taiwan Health Insurance, but there's one special condition is that for Taiwan, and if the children go to the hospital, go to the ER room, the second time they go to a hospital, the ER room for the same condition, and we usually admit this patient and into in the hospital ward, and this is if this patient hospitalized due to asthma acute exacerbation, and this patient will be included in our research. Yeah, so I think most of the people we enrolled in our study is on only visit the ER once for the control days.
Okay. Thank you for your answer, and I think we have, because time limit, we have to move on to the second talk
Thank you.
this morning. Okay. Okay. The second talk this morning will be presented by Dr. Haixin Gu from Chang Gung Memorial Hospital at Linkou, and the title of this talk is Graded Blood Metabolic and Airway Microbial Analysis for IgE-mediated childhood asthma. So please play the video for this talk.
Hello everyone, I'm Haixin Gu from Taiwan, Chang Gung Memorial Hospital. It's an honor to present here. In the following 7 minutes, I will talk about the idea of my research, integrated blood metabolic and airway microbial analysis for IgE-mediated childhood asthma. Asthma, a commonly seen disease in childhood, can be classified into non-atopic and atopic by the serum IgE levels. Also, microbiota in airways have been reported to be associated with atopic asthma in our previous study. In the study, by using metabolomics-based approach, we would like to discover the molecular mechanism for different asthma endotypes and their association with airway microbiome. So, for the metabolomics analysis, we collected the blood samples using NMR analysis to get the metabolite spectrum and classified them into groups by IgE levels. We compared each group, including the Canol plot heat map. We also analyzed functional metabolic pathways through KEGG database, and finally correlated our findings to clinical conditions as well. This is the study design for lung microbiome and asthma. We choose a case control study, and we use the HiSeq Illumina platform for the children around 3 to 5 years old, and collect their source swab samples by using the 16S RNA amplification to identify the airway microbiome. This is the microbiome analysis flowchart. We use the software QIIME to get the operational taxonomic units and to further identify the diversity and richness of the airway microbiome. At last, to find out the differential abundance of microbiome between the asthma and healthy groups. This is the result of the epidemiologic characteristics of the children enrolled in this study. A total of 53 subjects were enrolled in this study, including 28 children with asthma and 25 healthy controls. As previous study, there was a significantly higher total serum and mite-specific Ig levels in children with Ig asthma in comparison with non-Ig asthma and healthy controls as well. These were the results of metabolites identified using Genomics NMR suite and metabolites discriminated between each groups. We found 6 metabolites to be significantly different by p-value between non-Ig asthma and control, and 3 between Ig asthma and controls. To make it simple, this is the Venn diagram showing the association between the metabolites identified in each groups. Among the 6 metabolites mentioned, 4 of them were unique for non-Ig asthma, and acetic acid was unique for Ig asthma. Also, there were 4 metabolites discriminated between IgE and non-Ig asthma. Totally, these 7 metabolites appeared to be Ig-related and associated with asthma. This heat map showed a further Spearman's correlation analysis to evaluate the correlation between blood metabolite and serum Ig levels. The 7 Ig asthma-related metabolites were strongly correlated with total serum Ig level, either positively or negatively. Also, there was a strong correlation between metabolites associated with Ig asthma and non-Ig asthma. We further put these metabolites into metabolic S-weight analysis. Metabolite associated with non-Ig asthma indicates that the glycolysis may play significant roles in this disease mechanism. On the other hand, we found that Ig asthma associated with metabolites were mainly enriched in pyruvate and acetyl-CoA metabolism, suggesting pyruvate metabolism to energy through acetyl-CoA may play a crucial role in IgE production in response to allergens. Also, several papers had noticed microbiome to process these metabolites through its catabolism. To find out the association between blood metabolome and airway microbiome, we analyzed the data and showed the result through this heat map. And we found that the metabolites associated with Ig asthma were strongly correlated with airway microbiota. Acetic acid is a microbial-derived metabolite. It's also one of the short-chain fatty acids produced by bacteria. Fusobacterium is a genus of anaerobic gram-negative bacteria of the respiratory flora with increased invasive properties in an inflammatory setting. There is also high abundance of Fusobacteria species in asthmatic children. A significant positive correlation between acetic acid and Fusobacteria species in this study indicates the existence of the host microbial interactions in asthma phenotypes. So, in conclusion, metabolomics reveals microbes-related metabolic pathways associated with IgE in childhood atopic asthma. For example, we see the relationship between Fusobacteria species and acetic acid, suggesting host microbial interactions in asthma endotype. This study provides a molecular mechanism for the impact of airway microbiome on asthma endotypes by using the metabolomics-based approach. So this is the end of my presentation. Hope you enjoy it, and thank you for your attention.
Okay, thank you for your presentation. And now we are Q&A session for this talk. See if there is any question from the chat room. If anyone, okay. Maybe I can ask some question as a moderator. One question. We know that gut airway microbiomes are linked to some phenotype of asthma, so-called gut lung measure blood metabolic product related the metabolic pathway with the airway microbiome. So my question is, because we all know that the human gut is the most densely colonized organ in our body. So my question is, Where are the blood metabolic products coming from? GI microbiome or airway microbiome? Because asthma is linked to both gut microbiome and airway microbiome. Measure the product from blood, not the airway. So that's my question. My question is, these products come from airway microbiome or gut?
Okay, thank you for your question. And yes, this is a very good question that both the gut and the airway microbiome have some relationship. They may influence the metabolic levels in our blood. And there are some studies have noted that both the gut microbiome and the airway microbiome has to related. So in our study, we choose the respiratory the bacteria in respiratory tract because I think this is very straightforward. This is a very straightforward result if we found that since asthma is a respiratory disease, and we also found some doubt that this metabolites to be related to the airway respiratory bacteria. And so in the future, maybe we can also do some research in the gut bacteria.
Okay. Because time is also limited, so we have to close this session of this talk, and I'll hand over to next moderator for the other talks.
Okay, thank you, Professor Lin. So we just have two pass, and next our moderator is Professor Zhongming Chen. Please start.
Thank you. I'm pleased to introduce the next topic. The title is Soluble Perennial Cyclase Activation Prevented Postnatal Closure of Ductus arteriosus in Neonatal Rate, presented by Dr. Yi-Qing Liu from Department of Pediatrics at Kaohsiung Medical University Hospital, Kaohsiung, Taiwan. Please welcome Dr. Liu. Please start.
Good morning, ladies and gentlemen. It's my honor to share our study, Soluble Guanine Cyclase Activation Prevents Postnatal Closure of Ductus arteriosus in Neonatal Rate in this Congress. The ductus arteriosus is a vessel connecting aorta and main primary artery and plays an important role in fetal circulation. Delayed closure of DA attributed to pulmonary edema and respiratory failure in prematurity. However, PDA is life-saving in patients with dato-dependent congenital heart disease. The closure of DA involves vasoconstriction and vascular remodeling. The DA remodeling is caused by extracellular matrix deposition, proliferation, and migration of smooth muscle cells. Current medication for regulating DA parency is mediated by prostaglandin E cyclin AMP pathway. We use CAS inhibitors such as indomethacin or ibuprofen for PDA closure in neonatal with heart failure. In patients with dato-dependent CHD, we use PGU1 for keeping DA parency. However, this agent has significant adverse effects. The CAS inhibitor can induce renal failure or GI bleeding. The PGU1 may cause apnea or fever. So, do we have other alternative agents with less side effects for regulating DA parency? Sinacigua is a SGC activator, which can activate cyclic GMP protein kinase pathway to cause vasodilatation and anti-remodeling on pulmonary hypertensive vessels. As a result, we hypothesize that sinacigua can keep DA parency by vasodilatation and anti-remodeling effect. We also want to explore the underlying mechanism by use of angiotensin II. Our experiments include three components. In vivo, we check the DA morphology and histology. Ex vivo, we evaluate the vasodilatory effect by measure DA vascular tension. In vitro, we use DA smooth muscle cells to explore mechanism of proliferation and migration. In vivo study, we inject sinacigua in neonatal rate at birth. After 2 hours, we check the DA morphology and histology. In control group, the DA is patent at 0 hour. After 2 hours, DA closed. In sinacigua group at 2 hours, the DA is still patent. The DA to PA ratio is significantly higher in sinacigua group at 2 hours. In histology, the lumen of DA is obstructed with intimal thickening in control group at 2 hours. In sinacigua group, the lumen of DA is still patent with less intimal thickening at 2 hours. We demonstrate that sinacigua can prevent DA closure and had an anti-remodeling effect in vivo study. In its vivo study, we evaluate the vasodilatory effect of sinacigua. We sacrifice the neonatal rate and take out DA. Then we add oxygen, which causes vasoconstriction. Then we use sinacigua in different concentration. In the concentration of 10 and 100 nanomolarity, the tension declined obviously. To identify our hypothesis of vasodilatation through the pathway of cyclic GMP and protein kinase G, we perform immunofluorescence assay of cyclic GMP and add protein kinase G inhibitor. In the immunoassay study, the expression of cyclic GMP decreased obviously in control group at 2 hours, and the expression of cyclic GMP was preserved by sinacigua at 2 hours. To identify the vasodilatory mechanism, we pretreat DA ring with protein kinase G inhibitor KT5823. The relaxation effect of sinacigua was attenuated by PKG inhibitor prominently in the concentration of 10 and 100 nanomolarity. In vitro study, we use angiotensin II to identify the sinacigua effect on smooth muscle cell proliferation and migration and the underlying mechanism. Angiotensin II can induce smooth muscle proliferation, and the proliferation was attenuated by sinacigua dose-dependently. Angiotensin II also induced smooth muscle cell migration, and the migration was inhibited by sinacigua dose-dependently. Angiotensin II also activates RS production, and the RS production was attenuated by sinacigua dose-dependently. Angiotensin II can cause MAPK signal pathway activation to induce phosphorylation of ERK and JNK, and the activation was attenuated by sinacigua dose-dependently. A similar result was also noted in the pathway of protein kinase B. So in vitro study, we demonstrated the anti-remodeling effect of sinacigua by inhibition of smooth muscle cell proliferation and migration, RS production, MAPK, and protein kinase B signaling. In our study, we demonstrate that sinacigua can keep DA patency by vasodilatation through the pathway of cyclic GMP protein kinase G, and had anti-remodeling effect by inhibition of MAPK, RS, and the protein kinase G pathways. This study implicated that SGC activation or inhibition can be a promising therapeutic target in regulating DA patency, and can be applied in neonates with hemodynamic significant PDA in the future. Thanks for your attention.
Thank you for Dr. Liu's presentation. We have one question from an international reviewer. Could you tell us what are the side effects of sinacigua in humans?
Thanks, your problem. The major side effect is hypertension. The reported incidence is about 10%.
Okay, thank you. I have one question. How did you decide the dosage in animal study, you used the 10 milligram per kilo. How did you, for human study, or in human first, how did you decide the list dose in animal study, 10 milligram per kilo?
Actually, we list dose is by previous judged by previous study result.
By previous in vitro or in vivo study?
In vivo animal study.
Okay. Dr. Liu, do you have any future plan to compare the clinical efficacy of Sinaxicor and PGE1?
Actually, the major side effect of PGE1 is apnea and fever. Because apnea may induce, maybe we have to intubation with the neonate. So we hope to use this agent and cause less side effect of respiration.
Okay. And the last question from Dr. Lin. Do you perform the experiment on other vascular tissue?
In our research group, you mean? Actually, we perform this study just in the issue of ductus arteriosus.
Okay, thank you. Because time is up, we give the time to the master. Thank you.
Thank you, Professor Chen. So the next moderator will be Donghao Xu. Let's welcome Professor Xu.
Thank you, Professor Li. It's my pleasure to moderate the next two topics. The first topic is presented by Yoon Hong Man from Department of Pediatrics, Prince of Wales Hospital, the Chinese University of Hong Kong. Topic is childhood OSA prediction by the anatomic variables in upper airway MRI. Please start.
Hello, I'm Yun Hoi Man, a postgraduate student from the Department of Pediatrics from the Chinese University of Hong Kong. This presentation is about childhood obstructive sleep apnea prediction by the anatomical variables in upper airway MRI. In children, OSA is attributed to prolonged partial and/or intermittent complete upper airway obstruction. Anatomical causes such as adenotonsillar hypertrophy, obesity, and craniofacial anomalies can cause narrowing or a more collapsible upper airway, which contributes to the development of OSA. Pharyngeal length, cross-sectional area of the narrowest airway, and lateral pharyngeal wall thickness can affect the airway collapsibility. The pharyngeal length was reported to be a more important OSA determining factor than the airway cross-sectional area. In previous study, we found that lateral pharyngeal wall thickness correlates with OSA severity. Therefore, this study aimed to evaluate the OSA predictive ability of these upper airway anatomical variables. We recruited prepubertal children suspected of OSA to perform MRI and overnight polysomnography. OSA was defined by OAHI equal or larger than 1. MRI was performed during wakefulness, and subjects were aligned in the Frankfurt plane. The pharyngeal length was measured from the hard palate to the tip of epiglottis. To adjust for the effect of age, the age-adjusted pharyngeal length was calculated by the standardized residual. Other anatomical variables were measured on the transverse plane. The smallest airway at the retropalatal level was identified. Then the cross-sectional area of the airway was measured, and the width and length of that was calculated for the width-length ratio. Also, we measured the LPW thickness of both sides and summed as the total LPW thickness in both transverse and oblique dimensions respectively. The transverse LPW thickness was defined as the distance between the middle border of pharyngeal fat pads and the lateral edge of the airway. The oblique LPW thickness was defined as the distance between the internal carotid artery and the edge of the airway. For statistical analysis, Pearson correlation was performed on the anatomical variables and the log transformed OAHI. Group comparison was performed using t-test, and effect size was calculated using Hedges G. Classification models were built by logistic regression and CART-tree model. 70% of the subjects were used as training data to select predictive variables for OSA. The model accuracy was then evaluated by a confusion matrix using the remaining 30% of the subjects. This study included 27 subjects with a mean age of 8.7 years old. 20 of them were males. By PSG, 15 of them were classified into OSA group and 12 of them were non-OSA group. The correlation analysis showed that pharyngeal length and LPW thickness were significantly correlated with OSA severity in terms of log transform OAHI. The oblique dimension of LPW thickness and airway cross-sectional area almost reached statistical significance, while the airway width-length ratio did not correlate with OSA severity. Group comparison was performed. The OSA and non-OSA groups had no significant differences in anthropometric data. The OSA group has significantly larger LPW thickness in both transverse and oblique dimensions. The effect size was 0.8 and 0.88 respectively. OSA group had larger pharyngeal length, and the difference was more prominent after adjusting for age. The mean SAT score for OSA group was 0.21 compared to negative 0.68 in non-OSA group. The effect size was 1.1, the largest among the anatomical variables. The airway cross-sectional area and width-length ratio were not significantly different between OSA groups, but the effect size was medium to large. Using the oblique LPW thickness, adjusted pharyngeal length, airway cross-sectional area, and width-length ratio as independent variables, the logistic regression model gave an accuracy of 88.9% to predict OSA. The CART model selected the age-adjusted pharyngeal length and the width-length ratio of the airway as classification criteria, giving an accuracy of 77.8%. With the selection criteria, a small adjusted pharyngeal length, meaning a shorter pharynx, was predictive of no OSA. For a larger adjusted pharyngeal length, if the airway width-length ratio is larger than 2.2, it was predictive of OSA. This study has a limitation of small sample size, making the machine learning process less representative. But due to the high cost of MRI and PSG, we were only able to have the current data set subjects at this moment. To conclude, the anatomical variables of the upper airway, including the LPW thickness, adjusted pharyngeal length, airway cross-sectional area, and width-length ratio, were predictive of OSA severity in different models. That's all for my presentation. Thank you.
Okay, thank you, Dr. Mann. We have many questions for you from the floor. The first is that airway obstruction is a dynamic condition, and MRI is the exam that upper airway is in a fixed time point. Do the kids also have dynamic examination like bronchoscope?
For this study, we don't have other dynamic examination like bronchoscopy.
Okay. The second and the sixth question is similar that how do you find this variable in the MRI can help clinically in managing children in suspected OSA?
I think this study is give us some insight in how the craniofacial structure and the anatomical structure that can affect the OSA. And so current treatment are usually as tonsil, the surgery to remove the soft tissues. So for some children, their craniofacial structure may be different. So the treatment may when we consider the treatment, maybe we can also think about how these other structure may affect the surgical outcome.
Okay. The next question is that human breathing movement may change the airway during the different breathing stage. How to control this confounder factor in this study?
When we do the MRI scans, we ask the children to to breathe through their nose normally and ask them to refrain from swallowing. So the radiographer will take the photos when it's during the expiration. But of course, there may be some difference. We try to control it, but sometimes the children may move a little bit, and that may vary a little bit.
Okay, thank you very much because the time is limited. So we'll move on to the next topic also by you. So the topic is validation of sonographic measurements of lateral paropharyngeal wall thickness in children. Please start.
Hello again, I'm Yunhoi Man from the Department of Pediatrics, the Chinese University of Hong Kong. This presentation is about validation of the sonographic measurement of lateral paropharyngeal wall thickness in children. This study was a collaboration with the Department of Imaging and Interventional Radiology in the Prince of Wales Hospital, the Chinese University of Hong Kong. Lateral paropharyngeal wall thickness indicates the distance between the wall of pharynx and the internal carotid artery. LPW thickness is a potentially useful anatomical marker of childhood OSA. Measuring LPW thickness can be by MRI and ultrasonography. Ultrasound is more readily available, technically less demanding, and more cost-effective. However, its validity of LPW thickness measurement has not been verified in children. Therefore, this study aimed to assess the intra- and inter-operator reliability of the sonographic measurement of LPW thickness in children, and to validate the measurement against MRI measurement. We hypothesized that the sonographic measurement of LPW thickness is valid and reliable. Prepubertal children with suspected OSA were recruited. All of the subjects performed PSG. LPW thickness was measured by both ultrasound and MRI. For ultrasound, the subjects were positioned supine on the examination couch and their neck slightly extended, supported by a soft pad, like this figure. The internal carotid artery was identified with color application. The lateral wall of the pharynx appeared as an echogenic line on the real-time ultrasound, indicated by arrowheads here. Whereas the lumen of the pharynx was completely obscured by gas shadowing, shown by an open arrow. The LPW thickness was measured as the distance between the internal carotid artery and the echogenic surface of the pharynx in an oblique coronal plane, represented by the orange arrow. The LPW thickness on both sides was measured 3 times on 3 separate images, respectively, and the mean value of LPW thickness of the left and right sides were summed as the total LPW thickness for analysis. The measurement was repeated on the same day by the same operator twice for calculating the intraoperator reliability, and repeated by another operator for calculating the interoperator reliability. For MRI measurement, the LPW thickness was measured from the image that captured the smallest airway cross-sectional area at the retropalatal level. The transverse LPW thickness was defined as the distance between the middle border of parapharyngeal fat pads and the lateral edge of the airway. The oblique LPW thickness was defined as the distance between the internal carotid artery and the lateral edge of the airway. Intra-class correlation coefficient was used to examine the intra and inter-operator reliability. A two-way random model was used. The agreement between the LPW thickness measured by ultrasound and MRI was assessed by ICC with a two-way mixed model. The agreement was also evaluated by Band-Altman plot. The mean of the difference with a bias of 1.96 standard deviation denotes the limit of agreement. 32 children with a mean age of 8.8 years old were recruited. 25 of them were males. The intra and interoperator reliability of the LPW thickness by ultrasound were good, with an ICC of 0.91 for intraoperator reliability and 0.84 for interoperator reliability. For the LPW thickness by MRI, only the oblique dimension is presented here. The agreement between the ultrasound measure and MRI measure LPW thickness had an ICC of 0.65. This was acceptable, but due to the different imaging planes of LPW on ultrasound and MRI, which is slightly different, so the agreement is only acceptable. Meanwhile, the Band-Altman plot demonstrated a mean difference of 0.075 cm and a 95% limit of agreement from -1.1 to 1.25 cm. To conclude, the sonographic measurement of LPW in children demonstrated good intra and inter-rater reliability and an acceptable agreement with MRI measurement. Ultrasonography is a valid method to assess LPW thickness in children. This study was supported by the direct grant for research from the Research Committee of the Chinese University of Hong Kong. That's all for my presentation. Thank you.
Okay, thank you very much. We have some questions from the floor. The first one is that, do you do this dynamic or static? Because it's inspiration or expiration when you do the measurement?
Just like the MRI studies presented, and it's all done during expiration.
Okay, so it's done in the expiration phase. Okay, another question is that which one between the echo and the MRI, which one is more related to the clinical symptom sign or clinical severity?
For the ultrasound and MRI, the correlation with the OSA severity, I'm not very sure, but as far as I remember, it should be the MRI outcomes are more correlated with the clinical symptoms.
Okay. And did you do the sample size calculation? What was the ideal number of the children required, the size number?
We did a sample size calculation based on our pilot study on the LPW thickness between OSA and non-OSA children, and the minimum number to validate the difference was 32, which is our current number.
Okay. And another question, some factor might affect the LPW thickness, like after talking too much. So do you use the same situation to do the sonography as the MRI? Is the same situation for the children?
We asked the children to come back to do the MRI, and on the same day, after they do the MRI sessions, we'll ask them to do the sonography.
Okay. So would you recommend MRI for everyone who is suspected with the OSA in your clinical practice or echo?
I think ultrasound is more practical because if we need to do MRI for everyone, it will be very costly and it takes very long time. And especially for young children, they may not be very cooperative to do MRI, and because we are doing it during wakefulness, so we will only do it for the echo.
Okay, that's question. There are some artifact in the echo examination, especially when you do with some air. Is there a problem for you?
We'll take the measurement 3 times, so this difficulty I try to minimize.
Okay, thank you very much. Thank you.
Thank you.
Thank you. Thank you for Professor Zhonghao Xu's moderation. So the next section, we will go to Professor Deming Wang, please.
Hello, everybody. I'm Dr. Wang. And the last topic is presented by the Dr. Nitin Joshua, come from India. He will present acute gastric injury in critical ill children, impact on clinical outcome. Dr. Dosha, please. Slide, please.
Good morning. I'll be presenting our study, which is acute gastrointestinal injury in critically ill children and its impact on clinical outcome. The GI tract is injured in critically ill children due to various mechanisms, including hypoperfusion and reperfusion injury, hypoxemia, fasting-related epithelial atrophy, and bacterial infections. Once injured, gut can be the driving factor for multi-organ dysfunction by different mechanisms like increased GI permeability, which releases bacterial toxins and endotoxins into circulation, altered gut microbiota with colonization with pathological organisms, and bacterial translocation to cause systemic infections. Bowel inflammation can release cytokines into the circulation and can cause systemic inflammation. But GI dysfunction is not well described, and GI dysfunction is not part of any of the multi-organ dysfunction scores. In 2012, European Society for Intensive Care Medicine defined acute gastrointestinal injury, AGI, for critically ill adults in 5 categories, AGI grade 0 to 4 with increasing severity. Presence of AGI is associated with increased mortality, which has been seen for adults in various studies, but there are no pediatric studies of AGI in children, and there are no good definitions for pediatric AGI. Objectives of our study was to estimate burden of AGI in critically ill children aged 1 month to 18 years over first week of pediatric ICU stay. Secondary objectives were association of AGI with clinical outcomes, comparison of AGI with PILOD-2, which is an established multi-organ dysfunction score, and characteristics of children with AGI versus without AGI. For burden of AGI, we chose pediatric adaptation of ESICM AGI definitions. For outcomes, we studied 28-day mortality, mechanical ventilation duration, length of PICU stay, and hospital-acquired infection. For characteristics of children with AGI, we studied age, gender, nutritional status, shock, mechanical ventilation, and disease severity. AGI grade 0 is no GI symptoms. 1 is transient self-limiting symptoms. 2 are symptoms severe enough to require intervention but improve with intervention. 3 are severe symptoms which cause worsening of multi-organ dysfunction or which persist and progress despite intervention. Grade 4 are dramatic life-threatening symptoms like bowel ischemia with necrosis, hemorrhagic shock, or abdominal compartment syndrome. This was a prospective observational cohort study from a tertiary care center in North India. We included children between November 2017 and June 2019. Inclusion criteria was children admitted to pediatric ICU aged 1 month to 18 years, and exclusion criteria were history of chronic gastrointestinal illness or elective admissions. Written informed consent was taken from all the guardians, and the study was approved by ethics committee. GI symptoms were recorded daily by the pediatric ICU team, and they were classified by principal investigator into AGI grades. Daily pillow to score was calculated for 7 days. Children were followed up for outcomes till the discharge. With estimated prevalence of 46% from adult study and a precision of 7.5%, our target sample size was 170. During the study period, we had 367 admission. We screened 170 children, of which 19 were excluded, 6 had elective admission, 4 had malabsorption, and 9 refused consent. So finally, we included 151 children in our study. Baseline characteristics of the included children are: the median age was 48 months, 57% were male. There was significant malnutrition in our cohort. The most common system involved was respiratory system in 47%. PIM3 predicted mortality was 7%. 79% had mechanical ventilation and 67% had shock during the first week. We could start enteral nutrition for 75% during the first week of admission, and parenteral nutrition was given for 5%. Prevalence of AGI in our study was 47% with 95% confidence interval from 38.9 to 55.3%. AGI grade 1 was seen in 22%, 2 in 16%, 3 in 7%, and 4 in 2%. We found that 28-day mortality was significantly increased in children with AGI to 48% compared to children without AGI where it was 15%. Also, we found that 28-day mortality increased progressively from grade 0 to grade 4 of AGI from 15% to up to 100%. We adjusted association of AGI with 28-day mortality by age, nutritional status, PIM3 and day 1 pillow to score, which are marker for baseline disease severity, and there was significant association between AGI grades and 28-day mortality with odds ratio of 1.89. Though we did not find any significant association of AGI with other clinical outcomes, including PICU length of stay, duration of mechanical ventilation, and hospital-acquired infections. When comparing AGI grades with individual pillow to component, we found that AGI grades, cardiovascular and hematological component of pillow 2 showed significant association with 28-day mortality. While comparing characteristics of children with and without AGI, there was the children with AGI were significantly older and they had worse baseline disease severity compared to children without AGI. And 76% of children with AGI had shock compared to 41% without AGI. So strength of our study are that it's a novel concept in pediatric intensive care. It was a prospective study design, so takes care of some of the biases of retrospective studies. Limitations are that it was an observation period was limited to first week of pediatric ICU stay, so we could have missed some children who developed AGI during the second week or third week. Also, this was a single observer had classified AGI, so there could be significant inter-observer variability, which we could not document. Sample size could not be completed, but with a sample size of 151 patients, we had a reasonable precision of 8.2%. So to conclude, AGI is present in nearly half of critically ill children and it is associated with increased 28-day mortality. It can offer a useful ordinal scale to quantify GI dysfunction in critically ill children, and there is need for larger study for confirmation of our findings and identification of risk factors for AGI. Thank you.
Thank you. Introduction, so new concept. Now it's a Q&A stage. Is AGI an independent predictor of severity of illness? Did you consider co-founders like hematology problems?
So, like I presented in our presentation, so we adjusted for one baseline disease severity, which included TIM3 as well as day 1 pillow 2 score. So day 1 pillow 2 score has 5 components, which also takes care of hematological abnormalities. And also when we compared AGI with 28-day mortality and individual pillow 2 scores, because it's a like established organ dysfunction score, in that also it was adjusted for various other organ dysfunction, and it was still associated with significant, it still had significant correlation association with the 28-day mortality.
I have two questions. How do you categorize, what's your standard for categorization into grade 1, 2, 3? Because patient's condition at the same day might be grade 1, grade 2, grade out from grade 2 to grade 2, grade 1 fluctuation. So how do you sure to categorize into grade 1, grade 2, or grade 3? This first one. And the second one is I saw the almost 80% about the enteral feeding. So is there, because the patient during first week, the clinical station is not stable, so it might be just keep a 2 meal, 3 meal enteral NPO. So how do you categorize patient into enteral feeding or TPN support?
So the first one, we assigned these grades daily from day 1 to day 7, and worst grade was taken. So if a patient had on day 1 AGI grade 1 and on day 3 had AGI grade 2, so we took it as grade 2. So classified it as grade 2 because that's the worst AGI grade over the first week. And so this is how we classified into grade 1, 2, 3, and 4. And second question is this enteral nutrition, because some of these were very sick children. So we could start enteral nutrition in around 75% during the first week. And we used parenteral nutrition in around 5%. So there might be some overlap also that some children may have got both of these, but this was like overall pattern, and around 25% we could not start during first week. So some of the children could have died on day 3 or day 4, and some of the children might have started nutrition after first week of entry.
Okay, thank you. Because time limit, this project. Thank you.
Thank you, Professor De Minghua.